Today's case, a woman who had uterine artery embolization for a submucosal fibroid. Now, she presented with foul-smelling discharge and a fibroid almost prolapsing through the cervix, which she could see it herself. Now, remember, this scenario is a bit time-sensitive. You need to think necrosis, infection, sepsis risk, and potential hemorrhage. So we need to act calmly and decisively. The submucosal fibroid, usually they sit right under the endometrium, right over here. This is the entire uterus, this is the muscle of the uterus, and this is the inner lining. So at times, they protrude through the uterine cavity. Uterine artery embolization works by blocking the fibroid's blood supply, leading to ischemia and shrinkage. Now that's great for intramural or subserosal fibroids, but remember, with submucosal lesions, the devascularized tissue can detach and migrate, causing self-expulsion, offensive discharge, cramping, and sometimes even fever. Now, this is a risk which is known after UAE in cavity distorting fibroids. So very important to let the patient know about this. The initial steps are usually observation. You get an IV access, give them some broad spectrum antibiotics, especially if they have systemic signs of sepsis, and a quick ultrasound if available. We explain the plan, consent for vaginal removal, and be clear about the potential conversion to hysteroscopic, laparoscopic, robotic, or even open if bleeding or inversion occurs. These are the two main things that we usually worry about.
Action.
All right, as you can see over here, we'll pretend this avocado is the prolapsed submucosal fibroid. Usually the location is over here, but after uterine artery embolization, sometimes it can slip downwards. This is the uterus, 2 tubes and 2 ovaries. What you need to do is use a really good Ramplies with good force. Sometimes I use even 2 of them so that I get some really good traction. Now, with traction and counter traction, what we're trying to do is twist the fibroid out. We want to detach the fibroid from its attachment. So with slow traction and counter traction, usually it tends to come out easily. Almost as if you're fixing a light bulb or screwing a light bulb in, that's the kind of movement we need. And usually these devascularized fibroids almost auto-amputate themselves, which is why once it's out, make sure you send this off for testing. There is always a small risk of uterine inversion. So this inner part of the uterus where it's attached sometimes can come out, and it's called uterine inversion. So you need to be careful. Always keep uterotonics in place as well, and keep your emergency set available for a quick laparoscopy or robotic surgery. Now, aftercare, antibiotics if infected tissue, analgesia, and monitor the bleeding and fever, and arrange follow-up ultrasound to ensure that the cavity is clear. You need to make sure that you've got the entire thing out. Counsel while UAE can help with symptoms, especially with submucosal fibroids, but they do have a higher risk or odds of expulsion and infection post-procedure. For future management, you can discuss hysteroscopic myomectomy as the preferred approach for cavity lesions when feasible, especially for fertility preservation. The take-home message is foul discharge, prolapsing fibroids, especially post-uterine artery embolization, act now. Gentle traction, counter traction, twist, 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 twist. Be ready for inversion and bleed, and have a surgical backup plan. Thank you.